So this is what I'm going to talk about today. So general anesthesia, neuromodulation, altered states of arousal. Just acknowledge the funding sources that we've had for this research, in addition to the Pioneer Award, a Transformative Research Award, an Innovator Award to Patrick Purdon, and also our PO1, and then support from the Department of Anesthesia and my departments at MIT. These are my colleagues with whom I've had the good fortune to do this research. Patrick Purdon, who's at MGH, Nancy Coppell at Boston University, a mathematician, Shuna Keju, who's now our new chair of anesthesia at Mass General, Ken Salt, anesthesiologist at Mass General, Laura Lewis, who's now in the faculty at BU, she was my PhD student, Marusa Naranjo, who's my collaborator in Mexico, Miriam Sinechi, who's one of my PhD students, who's now a professor at USC, Shinung Cheng, who's a professor, was a former postdoc, who's now a professor at WashU, Ahmad Eskandar, neuroscientist, neurosurgeon, who's now at Einstein, and Sid Cash, who's a neurologist at MGH. And finally, a couple of graduate students, Indy Garwood, who's an HST student at Harvard MIT, Jacob Donahue, MD PhD student, who just finished up, and Suresh Chakrabarty, who's one of our postdocs, and Josefina, Josefina Correa, who's one of my PhD students in BCS. So what I want to do is I want to get this to work. So I'm going to talk about two things today. I'm going to talk about anesthesia-induced slow oscillation. I'm going to talk about reanimation, turning the brain back on after anesthesia. So let me just begin with a quick definition. So what is general anesthesia? So it's a drug-induced reversible state that consists of antinociception, meaning there's a loss of the ability to process nociceptive information, unconsciousness, amnesia, akinesia, you're not moving around while the surgeons are operating, stability and control, and we maintain stability and control of the physiological systems. So these are the key sort of descriptive features that we try to achieve when we put a patient in a state of general anesthesia. And it's often said that it's not clear how anesthesia works. And I want to, if I leave you with no other idea today, I want to at least have you appreciate that nothing could be further from the truth. And to do this, I'm going to talk about everybody looks for commonality of features in anesthesia. And the one thing that all anesthetics do is they produce slow oscillations. And they're produced differently, but they're the one feature that all the anesthetics produce. I want to give you a sense of some of those differences because they give us insight into the differences in the mechanisms of the actions of the drugs. So, but to do this, I'm just going to start with a little bit of history. And this is a diagram that made after the research by Frederick Brimme. So Brimme was a Belgian neurophysiologist who did some experiments back in the early 30s in which he looked at, he did these experiments in cats, and this is obviously projected onto a human brain, but the experiments were originally in cats. So he made a transection of the cord, separating the cord from the brainstem and the brain at A. And when he did that, and he measured the EEG on the cat's scalp, he saw a pattern that looked like this. And he called that the encephalocele, the isolated encephalon. The EEG looked awake appearing. And then he did a second set of experiments in which he transected here, sort of roughly separating the brainstem and cord from the brain. And he got a pattern that looked like this. And he called that the silvo-isolated, the isolated cerebrum. And he saw these sort of slow delta oscillations is what we would call them now. And that was the first hint that there was something in this region here of the brain that was associated with arousal. And now we know a lot more about the brainstem, the pons, the midbrain, and the medullas and their contributions to arousal. So the idea is if you take away inputs coming from these centers, you'll produce slow oscillations or slow delta oscillations. And each of the anesthetics actually does that as part of its mechanism. That's not the only mechanism, but as part of their mechanisms, they do this. And I'm going to give you a sense of that in the next few minutes. So, but to start, let me just show this little video, give you some idea of what happens to the brain under anesthesia. So in our operating rooms, we have EEG that we can place on patients' heads to monitor the brain under anesthesia. And so there are 4 leads. And this is an EEG that I made a few years ago. It's been almost, coming up on 8 years now. the lady who was going to have thyroid surgery, and she's about 60 years old. She weighs about 80 kilograms. I'm going to give her 150 milligrams of propofol, just a bolus dose, a very standard dose. And I'm going to just show you what happens to her, because the one thing is this phenomenon is not subtle. It's actually very, very obvious. So this is the EEG. So I've injected the propofol now. And the first thing you're going to see is it's going to get very, very noisy. And you'll see it right. All 4 leads. And that's because when you inject propofol into a small vein, like the one on the back, the ones on the back of the hand, it burns. And so she's tensing up. So that's just muscle artifact. Now, right here in just a second, you're going to see when the drugs go right here. So those are beta oscillations, about 12 to 16 hertz. Now she goes into slow oscillations. She's become unconscious right there. Slow oscillations get deeper. Now she goes flat and bursts. Goes flat and bursts. All right, so what did I just show you? So this is her awake, and so the EEG is about 5 microvolts or so, and low amplitude, high frequency oscillations. And then she traveled right down to here to the sedative state. This is these beta oscillations, about 12 to 16 cycles per second. And then right from there, she skipped over the state D and ended up down here in these large slow oscillations. This is very typical with bolus dosing of propofol on induction. And then from there, she came into burst suppression. And then between the bursts, she's in these very flat periods, which are isoelectric periods. So all these states here from D down to G are states you also see in coma. So it's no surprise that propofol is a drug-induced reversible coma. And this is the state that we try to hold you in with propofol when we're administering it, because you're adequately anesthetized here. You don't need to be down in these deeper states to be sufficiently unconscious to have surgery. But this is the sort of thing which can be controlled if you're using the EEG to monitor patients under anesthesia. And most anesthesiologists actually don't. They still use heart rate and blood pressure to track your brain state under anesthesia, ironically, as ironic as that may seem. And just to point out what the big loss of information that creates, if you look here, you see that as you go from the awake state down here to these states of coma, the size of the oscillations get to be quite large and quite exaggerated. And I would argue this is probably, so this is 5 microvolts. These are just somewhere on the order of 20 to 50 microvolts. And in the kids, they can be as large as 1,000 microvolts. So this is probably the strongest EEG signal there is. And we as anesthesiologists probably use it the least. And so that's a drawback. So this is what propofol looks like if you look at the spectrogram over time. So if you go back to the state here, this state here, you have a combination of slow oscillations and alpha oscillations here. And so that's what I'm showing you here. So this is someone who's anesthetized on a continuous infusion of propofol, and you see there's slow oscillations as well as alpha oscillations. And then we can draw diagrams like this to give us some insights into what's going on, because propofol works by enhancing GABAergic inhibition. And wherever you have interneurons, it's going to have its effects. So the cortex and the thalamus and the brainstem throughout the spinal cord. So it goes everywhere. So it's not sufficient to say, oh, there's just one mechanism. There are multiple things that are happening at the same time, particularly the brainstem, the thalamus, and the cortex. I'm just going to talk about the slow oscillation. I'm not going to say much about the alpha oscillation today. There's a whole story unto itself. So this is where we've gotten some of our insights into what's going on with the slow oscillations. So these are data which are recorded in some of our patients, subjects that have come to the hospital for epilepsy surgery. They have intractable epilepsy, and so they've failed medical therapy, so they're coming to have a surgical resection of an epileptic focus. So our neurology and neurosurgical team implants electrodes to identify the epileptic foci. In addition, they often implant research electrodes, and we take advantage of this because the electrodes are implanted. The patient stays in the hospital for a period of 5 to 7 days, allowed to seize off of medications, and then they come back to the operating room to have the electrodes removed and then to have a resection. So this is the spiking activity, human neuron. So you have this very unique you have this very unique experiment of nature where you can see what human neurons do under anesthesia. So here's a neuron which is next to this red electrode here, and the spiking activity looks quite irregular, as you might expect when the person's consciousness. But in unconsciousness, you have this very large modulation of the spiking activity by the slow oscillation. And we've been doing, so this was the best we could do in humans. But more recently, with the help of Earl Miller, and this is part of Jake Donahue's PhD thesis, we've been able to look at what happens in non-human primates during these states. And so here's the awake state here. Here's the field potentials. Here's the spiking activity. This is area 8A and PFC sort of up front, posterior parietal cortex and superior temporal gyrus. And you can see the sort of the low amplitude oscillations that I was showing you before, like we saw in the video or initially in the diagrams. And here's the spiking activity. And then this is the spiking activity that you see when the animal becomes unconscious. You see there are two main features. You see these very long, profound down states, which are seemingly modulated by the slow oscillations. And in addition, the spike rates have dropped dramatically. And to give you some idea of what that drop in spike rates are like, so here's a contrast. Over here on the left side, I'm showing you these spike rates across those same areas here, those same 4 areas here. And the spike rates as you, so this is a baseline before any drug is administered. You administer propofol, then there's a rapid decline in the spike rate. This is the period when the animal is unconscious, and here's when the animal recovers consciousness. So the key thing here is the spike rates are on the order of about 7 to 12 spikes per second. They're down to about 0.5 to 1 spike per second when the animal's unconscious. And I'm going to talk about this in a second, but if here's ketamine, here's an animal unconscious under ketamine, and the spike rates under ketamine are at the same rate as when the animal's awake. So a wholly different dynamic in ketamine compared to propofol. So in this case, in the case of propofol, the slow oscillations are doing 2 things. They're creating these very, very profound down states, and they're inducing this very, very large decrease in spike rate. And that's what we think is one of the major contributors to someone being unconscious under propofol. But let's turn to ketamine, because the dynamics of ketamine actually look quite different. So if you were to give someone just a sedative dose of ketamine, like the doses which are used to treat depression now, you would see high frequency activity here, like I'm pointing to, which is about 30 hertz. If you give them a dose of ketamine, which is sufficient to produce profound unconsciousness so you can conduct surgery, you have this very cool pattern, which is you have high frequency, then slow oscillation, then high frequency and slow oscillation. And that's what you're seeing here in this spectrogram here. So here's the high frequency, slow, high frequency, slow. And this is in humans. So this period here is about, between the slow and the high frequency, about 4 seconds or so. And remember, ketamine works by blocking glutamate, so NMDA receptors. And one of the key features, this was pointed out, I think, first by Bita Moghadam about 12 or 13 years ago, that at low doses, it has a higher affinity for the inhibitory interneurons. And what you see is that this is one of the major contributors to seeing this very, very large, this high frequency activity during the time at low doses. Whereas if you give a larger dose, you actually affect not only the interneurons, but also the pyramidal neurons. And these very profound, if you would, these connections right here, which come out of the brainstem, again, applying Brimade's principles. So we're looking for ways in which inactivation of the brainstem, among other things, could contribute to this. And so there are very rich glutamatergic projections coming out of these areas here, which can certainly be targets and contribute to these slow oscillations that we see. But the dynamic is quite different from propofol. And so here is an illustration from the non-human primate. You can see very profound slow period, high frequency period, but the two sort of coexist. So it's not that you just go simply from the gamma oscillation to the slow oscillations, but you go gamma, you have an overlap period, then you go slow, and you repeat that process. And so one of the things that Indy Garwood looked at, so these are data here from a non-human primate experiments. So actually, I should point out that these data that I was showing you before, these are from humans, and this is from the non-human primate. And here again, non-human primate data again, and the same sort of thing. You can see this sort of oscillatory pattern going back between high frequency oscillations and slow oscillations, and sort of here's a blow up of it. And then Indy used a hidden Markov model to characterize these states. You can see there are four very well defined states. There's the slow state, the two overlap states, the high frequency state, the slow state, the overlap states, and then the high frequency state, and these sort of repeat very, very regularly across time. All right, and remember the spike rates are high. The spike rates are at the rates at which they are at during the when the animal is conscious, and this is what they look like. So this is in sharp contrast to what I was showing you for propofol. The down states are actually quite small here, right? You can see the little breaks, and they approximately line up, across the various sort of cortical areas, and the spike rates are as high as they were when the animal was conscious. So this is a wholly different way in which this drug is producing unconsciousness compared to propofol. And this is just another illustration of this, sort of showing that these various down states are actually quite aligned, if you would, or the up states are quite aligned across the various cortical areas. So let me talk about nitrous oxide. And so this is actually in the operating room. This is what I saw on the monitor one day when I switched one of my patients from sevoflurane to nitrous oxide. And if you look, each one of these little vertical lines here is a second. And so this is a patient on nitrous oxide. And once I saw this, I came to understand why sniffing glue or sniffing nitrous oxide could kill you instantaneously. Because to produce oscillations like this, you have very, very profound shutdown of most likely inputs going from the brainstem up to the cortex. And this is what we often do. We often switch over to nitrous oxide at the end of a case because it's easier to wake a patient up from nitrous oxide than it is from, let's say, isoflurane, one of the inhaled ethers. So here the patient is on isoflurane, you switch to nitrous oxide, and it takes a while to happen, but you can see it starting to materialize. You see the spectrogram is breaking down. Then the person goes into these very, very profound slow oscillations. They look like this. And what's so interesting about them is they don't last. They're actually quite transient. And so so here the person goes from this state here into this sort of high frequency oscillation, and this is what's maintained. But again, if we think about Bremé's principle, again, the nitrous oxide also blocks NMDA receptors, and so it has targets here. You have these projections coming out of the brainstem, which could be the likely source of these slow oscillations, certainly contributing to them. But then why would this be transient? This is one of the things we don't understand. They last between 6 to 15 minutes or so, and then you get a high frequency pattern. So this is sort of one of these things that we're trying to trace down, but the slow oscillations are quite evident. And one final example, dexmedetomidine. Dexmedetomidine is an alpha-2 adrenergic drug that it is the closest of all the drugs that we have to one that produces a state that looks like sleep. And I'm just showing you that here. This state here at light doses of dexmedetomidine sedation, you have spindles like you can see here, which are just like the spindles you see during stage 2 non-REM sleep. And then at higher doses, you can actually see just profound slow oscillations. And you can see also spindles even here with very sort of deep sedation with dex. Now, what's interesting about these slow oscillations, even though these are very profound slow oscillations, they're not quite on the same order of magnitude as the ones that I showed you for propofol. And the patient is arousable here, whereas if you saw the same slow oscillations in a patient who's on propofol, they wouldn't be arousable. And so what would the targets be in the brainstem? So the targets in the brainstem would be here, the locus coeruleus, which releases norepinephrine, projects the preoptic area of the hypothalamus, central thalamus, up to cortex and up to basal forebrain. So this is, if we apply Bremé's principle, so this is probably one of the main contributors to these slow oscillations that we see here for dexmedetomidine. So again, a different mechanism for ketamine, a different mechanism for nitrous oxide, a different mechanism from propofol. And just some important factoids about slow oscillations. So here is a young child. if you have a child that's below 3 months of age and you give them one of the GABAergic anesthetics, all you see are just slow oscillations. And this probably just reflects a very young brain, where the alpha oscillations, which I didn't talk about, are produced by this thalamocortical circuit. There's probably not enough connections yet between the thalamus and the cortex to produce those oscillations. The other time we see slow oscillations is in older patients. They don't produce the alpha oscillations at all. And again, a GABAergic drug like sevoflurane, which is one of the, the inhaled ethers. And then a very important case, which is it's important to be aware of now, is that in patients that have overwhelming sepsis, they also produce just slow oscillations. Like this 34-year-old gentleman that I took care of a few years ago who had overwhelming sepsis because he had an infected arm from shooting up. He would come to the operating room to have his bandages changed. And one of the things that that I noticed when I put the EEG on him was that he had just slow oscillations. There was nothing there. I was surprised. He's a young guy. I didn't expect this. And then what I came to appreciate is that this is very typical in patients with sepsis. And when you think about it, it makes sense. The inflammatory mediators actually turn off the brainstem. And this is shown by Mark Ott at Washington University, that this effect is very, very real. It makes sense that when you're sick, when you have a cold or a flu, you don't feel like running a marathon. You want to sleep. So there's a physiological component of that. So you can imagine if you have overwhelming sepsis, that effect's going to be very profound. And this is actually quite relevant now because these are the sorts of EEG patterns that you see on patients in the ICU. They have these very profound COVID infections. They have these very profound slow oscillations, and many of them have extremely prolonged periods of recovery of consciousness even after their ARDS has resolved. So one final thing, reanimation. So we work a lot to turn the brain off under anesthesia. Maybe we should turn it back on. And this is something my colleague Ken Salt has been studying, because brain dysfunction after anesthesia is quite common. So let's see if I can play this. There we go. Play this here. So this is a rat that is receiving propofol, and he has an electrode implanted in his VTA. So what Ken is going to do is he's going to stimulate his VTA here, and watch what happens when he turns on the stimulation. So he's anesthetized with propofol. He doesn't turn the propofol off, but watch the first thing that happens when he turns the stimulation. See how the animal starts breathing like crazy? And now he gets up and he runs off. All right. So whatever Ken is doing has really had a profound effect on this animal's arousal. So is this animal conscious? Is he able to actually function? So to study this, Ken did another set of studies in which he trained animals to execute a behavioral task. They hit the correct light, they turn around and get a food reward. So what he does now is he anesthetizes the animal. He has this VTA stimulating probe in, and then the animal is going to be anesthetized. He's going to stimulate, wake him up. The animal's going to go back and start working, and then he's going to work for a while. Then he's going to turn the stimulation off. The animal's going to go out again. So this is an attempt to develop ways to actually precisely control arousal. So here's the animal, and he's anesthetized on isoflurane. So Ken's going to turn the stimulation on now. So he turns it on. So he looks for a food reward. Well, there's no free lunch, so he's got to work. So he turns around and hits the correct light, turns back around, gets a food reward. All right, so the anesthesia is still on, mind you. We didn't turn the anesthesia off, so whatever's happening is overpowering the anesthesia. So he turns around again, hits a little wobbly, but he's actually cognitively processing and executing the task. And I think he gets this next one wrong. He turns around, hits the wrong light. So that tells me he got it wrong. Okay, and now what he's going to do is he's going to turn around again, starts the next trial, and Ken turns the stimulation off. And the anesthesia takes over again, and he's out. All right. So what is Ken doing? Well, so he's taking advantage of this pathway here coming out of the brainstem again. So this is the mesocortical pathway starting in the VTA, going by the amygdala, the limbic system, amygdala, hippocampus, nucleus accumbens, going up to cortex. And we usually think about this pathway as important for reward, but it's also important in arousal and cognition. And so Chen has actually shown this with Ritalin. You can give IV Ritalin and generate a similar effect. And that's the clinical relevance of this. And as I've shown you, this is an electrical stimulation experiment, but he's also done it optogenetically, identifying particularly the D1 neurons. So this is something that we're actually studying now, and we're going to be doing clinical trials in humans, with Ritalin, to actually look at, waking patients up from anesthesia, because brain dysfunction after anesthesia is very prevalent, particularly in older patients. So here's what I've told you. The brain under anesthesia, this anesthetic state is created by the various drugs creating these oscillations, and pretty much all the anesthetics produce slow oscillations, but they do so through different mechanisms. However, one component of that is probably taking away projections, the activity of projections coming from the brainstem, and producing hyperpolarization of the cortex and probably the thalamus. And in addition, there are other things that are going on as well, but this is like one of the central features which you can see across the different drugs. But the nature of the way the pathways that are taken away are different for different drugs. And then the cortical actions are also different for different drugs. And I just showed you this idea of reanimation. Again, thinking in terms of circuits might be a way of helping to bring patients out of anesthesia, gain better control of anesthesia, and help reduce cognitive dysfunction, which I said is a real problem, particularly elderly after surgery and anesthesia. So thank you very much. I'll stop there.